Cultural competence and healthcare disparity. So let's start this off with a little disclaimer. I am not an expert on healthcare disparities. I am not an expert on cultural competency. This is not a topic that we will have one lesson on and move on. Healthcare disparities, and more heavily, cultural competence, should be a lasting theme throughout our courses together and your career as an athletic trainer. We will hopefully be able to bring in someone from the Office of Diversity, Equity, and Inclusion during your orientation or soon thereafter to discuss these things with you. You will consider different healthcare disparities in your classes, and you will need to practice and apply culturally competent care with every patient, athletic trainer, administration, other healthcare practitioners, or any other person you encounter. What I am. I do consider myself to be a proficiently competent individual in the realm of healthcare disparities and cultural competency. I believe I have a fair level of emotional and contextual intelligence that allows me to internally process and respond to various circumstances. I attempt to practice self-reflection on a regular basis, and I also attempt to educate myself on topics that I know I am less of an expert in to help increase my practice. Cultural competency versus healthcare disparities. Cultural competency is an ongoing journey. Attending one training, reading a book, or taking one course will not fulfill the needs of educational awareness surrounding cultural competency. It should be integrated throughout your time as a Master's of Science athletic training student. It is a conscious effort. According to our accrediting agency, the Commission on Accreditation of Athletic Training Education, or CATE, cultural competency is the ability of providers and systems to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery to meet patients' social, cultural, and linguistic needs. Populations can be defined by factors such as race or ethnicity, gender, education or income, disability, geographical location, for example, being in a rural or urban setting, or sexual orientation. Health disparities are inequitable and are directly related to the historical and current unequal distribution of social, political, economic, and environmental resources. Cultural competency, according to the CDC or Center for Disease Control, is defined as cultural competence is the integration of transformation of knowledge about individuals and groups of people into specific standards, policies, practices, and attitudes used in appropriate cultural settings to increase the quality of services, thereby producing better outcomes. According to the National Athletic Trainers Association, cultural competency includes patient values that are individual characteristics such as gender, race and ethnicity, sexual orientation, religion, and socioeconomic status that can influence health and well-being. Healthcare disparity, according to the CDC, healthcare disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Often, cultural competency and healthcare disparities are discussed together, but they are two different entities. Both of these things are the result of socioeconomic disparity, environmental threats, inadequate access to healthcare, individual and behavioral factors, and possible educational inequalities. So take a minute for yourself. Do you think one of these factors informs the other, such as cultural competency informing healthcare disparities? These are important to consider when we talk about our professional practice. Cultural competence. Sets of attitudes, skills, behaviors, and policies that enable healthcare providers to provide cross-cultural care that is respectful of and responsive to individual patient preferences, needs, and values. Gender identity may not match sexual assignment, and sexual assignment of male versus female is not all encompassing either. In 2018, the American Medical Association, or the AMA, revised the gender spectrum and includes now a more inclusive outlook. Cultural competence is the fundamental requirement in providing patient-centered care. If we refer back to our evidence-based practice course, patient values and preferences is one of the 3 platforms of evidence-based practice. So we can see how this primacy of the patient, or putting the patient first, is embedded throughout our entire curriculum. Culture often shapes patients' views of illnesses and well-being. It may affect the perception of healthcare and can even influence patient compliance and patient-reported outcomes. When we talk about some different cultural factors, they may include things like race, ethnicity, gender, and even sex. Race may include distinctive physical traits that vary among different populations. Ethnicity is a broader category of common racial, national, tribal, religious, linguistic, or cultural origin or background. Gender, there are a range of characteristics pertaining to and differentiating between femininity and masculinity. Sex refers to the biological differences between females and males, including chromosomes, sex organs, and endogenous hormone profiles. One of the first places to start when looking at cultural competence is seeing if you can identify any stereotypes or biases that you may have or are prevalent for different groups. By identifying these stereotypes or biases, that's the first place to start. Once we have identified those things, then we can work on understanding where they come from and increasing our care and knowledge of certain groups. Compassionate care may include things like empathy or sympathy. Empathy is understanding and sharing feelings of another. Empathy is the ability to emotionally understand what other people feel, seeing things from their point of view and imagining yourself in their place. Essentially, it is putting yourself in someone else's position and feeling what they must be feeling. Sympathy, on the other hand, is pity or sorrow for someone's misfortune. Sympathy is feeling bad for someone else because of something that has happened to them. We often talk about it and feel sympathetic when someone has died or if something bad has happened. Saying, "Give them my sympathy," or "I really feel for them," would be characteristics of sympathy. We also have emotional and contextual intelligence. Emotional intelligence is the ability to understand, use, and manage your own emotions in positive ways to relieve stress, communicate effectively, empathize with others, overcome challenges, and diffuse conflict. According to Daniel Goleman, there are 5 components to being emotionally intelligent: self-awareness, self-regulation, motivation, empathy, and social skills. Contextual intelligence is the ability to understand the limits of our knowledge and to adapt that knowledge to an environment different from the one in which it was developed. It is the practical application of knowledge and information to real-world situations. This is an external, interactive process that involves both adapting to and modifying an environment to accomplish a desired goal, as well as recognizing when adaptation is not a viable option. Health disparity and health inequities are important issues, especially for individuals of color and especially for Black patients. In 2001, a landmark study of healthcare found that a substantial number of Black, Latinx, and Asian patients in the United States did not get the same level of care as white patients. In primary care settings, Black patients experienced less participation in the conversation, less rapport building, less positive affect, and less communication regarding their medical condition. Many of these differences appear to exist even when education, income, and insurance coverage are the same as white patients. With that, we have to start looking at the reasons for these differences, which may be caused by cultural bias or a cultural disconnect between the patient and the provider. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So, when we think about healthcare disparity, what are some of these socially disadvantaged populations? Many of these populations are determined by race and ethnicity, gender, education or income, disability status, geographical location, or even sexual orientation. So, as we start discussing cultural competence and healthcare disparities, we can engage in some reflective practices. We can look and see how we can make ourselves more culturally competent. Are there any areas of healthcare disparity or cultural competency that you are or were surprised about? Can you identify any missions or goals of your own moral and ethical professional practice that are influenced by healthcare disparity or cultural competence? Are there any lingering questions, comments, or even concerns? For next week, we will look at an introduction to law, look at athletic training law at the local, state, and federal level, and organizational ethics and law. Here are some references for the content of this lecture.